Hello, my name is Dr. Joseph Butler. I'm an orthopedic spine surgeon based in Dublin, Ireland, and I'm pleased to have with me today Dr. Greg Schroeder, an orthopedic spine surgeon at the Rothman Institute and Thomas Jefferson University in Philadelphia. Today we're going to discuss the current trends in the use of biologics in spine surgery. And when we think about the vast array of biologics available to us today, we consider everything from autograft, allograft, demineralized bone matrix, ceramics, and of course, bone morphogenetic protein or BMP. So to kick things off, Greg, tell me a little bit about your use of autograft and allograft in your practice.
Sure. So, I think autograft is really the gold standard, right? Oftentimes we were talking about iliac crest bone graft, but I think in general, particularly in kind of simple one-level open procedures, I don't think oftentimes we're using iliac crest bone graft. At least I know I don't routinely use it. I don't think anybody at the Rothman Institute really routinely uses traditional iliac crest bone graft. But what we do use in every case is really the local bone. You know, whether or not you're doing posterior lateral fusion and you just have kind of the lamina that you're taking off in spinous processes, or if you're doing a TLIF and you have the facet that you can take out. I think using the local bone is really a great option. Unfortunately, a lot of times it's just not enough. And that I think is where the kind of different biologics, cage technology, things like that really come into play. So allograft bone, I think, pure allograft chips is a option to really kind of work as an extender. Right. When we think about biologics, we really want to look for things that are osteoconductive, osteoinductive, as well as the ability to actually create bone on its own. And, allograft really only falls into the mold of really being a scaffold. So this extends it, but it doesn't really stimulate bone growth. It doesn't have any really bone cells or growth hormones in them at all. So I think the role for allograft and allograft chips is as an extender, but realistically, I do think there are a lot of other options that probably give you a little bit more than just the allograft chips. Conversely, when we talk about allografts, oftentimes in the neck, I'll use structural allograft, or in the front of the spine, we use structural allograft. But even then, it's important to understand the limitations of it. You still need something to kind of help stimulate the bones to grow with allograft. I think that kind of brings us to, so Joe, what do you use besides that? Are there DBXs, ceramics, anything like that you use that really kind of moves it along?
Sure, certainly demineralized bone matrix, I think, is, although it doesn't provide a significant structural support, I think it's a very useful bone graft extender. It has, as you mentioned, both like an osteoconductive property in terms of the organic matrix of collagen and non-collagenous proteins, and it also has the osteoinductive element from its growth factors such as BMP, TGF-beta, and FGF. However, it's important to highlight that often there's significant variability with the products available on the market, and there is a little bit of variability in terms of their efficacy and the composition that they come in.
Right. I think that's a great point. I know, oftentimes one of the DBXs that we use at Jefferson has a significant amount of cellulose in it. And so you're looking at it and it's this nice structure and it looks good, but it's important to understand that cellulose is really just filler. It doesn't offer those things that you have. So I do think, when you're looking at the DBXs, you have to look at what DBX, and all of them aren't the same.
And as you mentioned, I would commonly use demineralized bone matrix in conjunction with local autograft, so spinous processes, laminae, and the facet joints, potentially in an instrumented posterolateral fusion. On the other hand, ceramics, which, as you know, are calcium-based synthetic grafts, they are purely osteoconductive, and they do have some advantages in terms of there's an element of mechanical strength, but also it comes in a wide variety of compositions, and there's a longer shelf life, and of course there's no concerns in relation to disease transmission. I would commonly use your tricalcium phosphate to load an interbody cage when doing ACDF surgery.
Right. I think that's a great option. There are also some people who for whatever reason, are uncomfortable with allograft, I think that ceramics are a great option, and those are times that I really use that as well.
Tell me a little bit, Greg, about your thoughts on the use on bone morphogenetic protein, or BMP, in practice today.
Sure. I think that it's important to understand that BMP2 is really only FDA approved for the use in the anterior lumbar spine. And so whenever I use it, in general, it is in the anterior lumbar spine. I think there have been a lot of concerns about BMP, the cost of BMP, the complications that are associated with BMP. And because of that, it's not something that I do routinely use in the posterior spine, although I know it has been routinely used in different places, particularly in things like MIS T-lifts, where getting the bones to heal is a real problem, because oftentimes in an MIS approach, you can't do as well of a disc prep. You also can't always get, you don't get a posterior lateral fusion at all, where if you're doing an open T-lift, oftentimes you can get a really robust posterior lateral fusion as well as the T-lift. But in general, I don't use it. I think one of the challenging things with BMP is that oftentimes, even when you talk about it, patients will ask you things about cancer. And I think there have been a couple of good articles. Jason Savage at the Cleveland Clinic really looked at a really large cohort and found really no link to cancer. I don't really believe that, but it's still something that having that discussion with your patient when you're talking about a spine surgery, when there are other options, it can oftentimes be challenging. There's also other issues, with seroma formation, heterotopic ossification, all of these, where I do think when you look at local bone plus other options, and specifically, cage options and things like that, that you may be able to not need it for kind of your routine case. As we're kind of talking about, I'm saying you don't need it maybe because there are some cage options. I think when we talk about biologics, I think really one of the natural extensions of the biologic discussion is really, all of the changes in cage development and what cages people are using, and really what's the evidence behind this. So Joe, what are you using from a cage standpoint?
Well, I think certainly 3D printing has, there's been an evolution, and it's likely to impact on our practice in the coming years. It's likely to impact potentially on our biologic selection. The development now of highly porous titanium alloy cages offers a number of potential advantages. There's increased mechanical stability with an highly porous titanium alloy cages, which are offering a number of key advantages in relation to our surgical options. We're having the potential to have increased mechanical stability from a high coefficient of friction. We also have greater load sharing with a low modulus of elasticity and less chance of stress shielding. But also we have these highly porous cages that are promoting significant bone ingrowth and ongrowth, and are potentially going to lead to greater biologic fixation. Me, for one, in terms of my own personal practice, I've been eliminating peak over the course of the past year or so because I have concerns in relation to pseudarthrosis development and the potential need for revision surgery.
And I would agree with you there that I have primarily used the porous coated titanium cages now at this point, and I think it does allow you to limit your biologics. The big issue with it, though, is that there's very limited clinical data on the porous titanium cages or the porous PEEK cages. When we go to these meetings, we see a lot of slides that have to do with basic science, but I think realistically now, us as a academic community, the industry that is really pushing these cages, we need to try to look at what are the real fusion rates in patients and what are the health-related quality of life outcomes. So thank you guys very much. Thanks, Joe. I think we've had a great discussion, kind of trying to highlight some of the key topics of biologics today.
Thank you.